has air and light and water. So if there's an area they're looking at and they see maybe there's an irritation in the stomach, they can flush with water that area. They're also able to take pictures. Their scope has a camera on it, so they can take pictures of the area, and they can also take biopsies. They can enter in into the scope. One of the things they can do is put a little biopsy forceps in there and take little teeny pieces and send it off to a lab so that to diagnose anything at the microscopic level that you might not see. So that's an EGD. But I'll first tell you about our patients come in to our area. We bring them into a pre-op area where we take their blood pressure, temperature, put them on a heart monitor. We start an IV on them, and we have anesthesiologists talk to them. We get their history to make sure that there's no reason that they're at high risk and they should not have this procedure done in our facility. Some of the people, if they have dialysis, poor kidneys, if they're very high risk, we might just stop right there and tell them they can't have their procedure. If there's somebody that we put on a heart monitor, this has happened where we put them on a heart monitor, their heart rate is above 150 and irregular, and that's called atrial fibrillation. So put them on a heart monitor with the anesthesiologist will talk with the physician, and they usually decide not to do that procedure in our hospital because they're too high risk. So all those things are done in the pre-op area, and we decide, is the patient safe enough to have their procedure? We get their IV started because we give sedation through the IV, and then we have their vital signs and everything as a baseline. Once that is established, and we establish what procedure they're having, then they go into the lab, and it's a different room. There is all the equipment in there. There's a nurse anesthetist who administers the anesthesia. The doctor is there who does the procedure. There's a tech who helps assist the physician with the catheters and the forceps, the biopsy forceps. Also gathers the specimens. The nurse takes a specimen, labels a specimen, puts it in a lab bag along with the patient's information that's been identified in their insurance information, so they know where it goes for testing. All that gets sent off, and we get the results of any specimens that we obtain within 7 days. So we are able to send those to our doctor and to their family physician, anything that they find. So a colonoscopy is something else that people have at our facility, and a colonoscopy is where we do the same thing. We bring them into the pre-op area, we get them ready for the procedure, and a colonoscopy goes through the rectum into the colon. We check the large intestine, which is about 4 to 6 feet long, and the scope again has light on the end of it, and camera, air, and water. So they puff up the bowel with the air, they go through with the scope, and if they come across what's called a polyp, and it's P-O-L-Y-P, they take those out if they're small enough. So anyone who is 50 years or older should have a colonoscopy for screening to take out polyps. Polyps can be of two types. They can be hyperplastic, or they can be what's called an adenoma polyp. An adenoma polyp is a type of polyp that can turn into cancer if it's left in there too long. The doctors tell the patients that adenoma polyp can go from being a polyp to a cancer in 6 to 7 years, I think is what they tell them. So anyone who has a polyp will have a repeat colonoscopy in less than 5 years. If it's an adenoma polyp, then they would have a repeat within 3 to 5 years. And that also depends on family history of colon cancer. So the person goes in, they have their colonoscopy. After they have their colonoscopy, you wake up, the doctor does suction out any of the liquid that's in there. I'll explain the prep for the colonoscopy in a minute. But they suction out the liquid, and they puff up the bowel with air. So when you wake up from a colonoscopy after your anesthesia wears off in the post-op area, you might feel crampy. and we ask them to bear down and push the air back out. In our area, we say leave grand blank air and grand blank. And so they push that back out. Once in a while, there might be a little bit of liquid there, but they get that, they feel better after that. And we are able to discharge our patients within 30 minutes of coming into the post-op area. The preparation for the colonoscopy is, there's several different solutions that one might have to have. The first solution that I can think of is Try Lightly, Go Lightly, or New Lightly. They all have this lightly name on them. But they are a large volume of fluid that causes one to evacuate the whole intestine. Small intestine, which is 20 to 30 feet, along with the 4 to 6 feet of large intestine. You start drinking the solution at 5 o'clock the day before your procedure. That day you will have been on clear liquids all day. Then you start drinking the solution at 5 p.m., 1 8-ounce glass every 15 minutes until it is complete. You do save 4 cups for the following morning, and before 6 a.m. you also take in the 4 cups of the solution, just to make sure that the intestinal tract is free from any debris or stool. So the people that come in should be having a clear liquid return is the question that we ask them. When did you finish drinking your solution? To make sure that they haven't got anything in their stomach which would compromise their sedation. And we also make sure that they have taken the solution and that there's clear yellow results, almost urine type, kind of like your urine is what's actually coming out. Just to make sure that there's, the doctor goes in and then he can see very clearly in there if there's